Greetings and welcome back for our next lesson. Today's topic is specialty-specific documentation errors in clinical practice. So this is really going to get into the meat of things with a lot of examples, and I really feel that this is one of the lessons where you may get the most usable information. So it could run slightly longer than the others, but let's dig in and see what we can do. So a common error is incomplete documentation, and for each of these topics I'm just going to jump right in, give you an example, and explain to you why it is an issue. So an example of an error and why it's an issue. So with incomplete documentation, like a patient's note not including their current medication list, or missing critical drug interaction information, is a serious deficiency. Missing details such as medications, allergies, and family history can lead to misinformed treatment decisions. For coding, this can result in an absence of key diagnosis codes affecting the diagnosis-related group assignment. And so that's like a bundle coding. I'm not sure if you have DRGs, but it can affect the severity level of the DRG or of the code, and ultimately lead to lower reimbursement that shouldn't be lower. We want you to be paid appropriately. During quality audits, the lack of comprehensive documentation can trigger red flags and require additional explanations, which potentially delay the audit process and can impact the hospital's quality ratings. And I said hospital on the previous slide, but it can impact hospital or provider facility ratings. Okay, so in this next example of inconsistent documentation, the nurse's notes state that the patient has no known allergies, but the physician's note mentions an allergy to penicillin. So we have conflicting information. So discrepancies between entries can cause confusion and potential harm if conflicting information is used for treatment. Inconsistent documentation can lead to coding errors such as dual coding for conflicting diagnoses, which may result in claim denials or payment delays. During quality audits, inconsistencies can suggest poor record-keeping practices and prompt further scrutiny and possibly lead to penalties. Clinical validation processes also become challenging as the documentation does not present a clear and accurate picture clinically. So in this next example, with inaccurate documentation such as incorrect information or misclassification, it would be something like a patient's chart incorrectly listing type 1 diabetes instead of type 2. Incorrect information can lead to inappropriate treatment plans and medication errors. In terms of coding, this can result in misclassification of the patient's condition, affecting the severity of illness and risk of mortality scores. These are crucial for reimbursement calculations. And inaccurate documentation can also lead to failed quality audits, as the errors can be perceived as intentional fraud or negligence. Clinical validation efforts are compromised as inaccurate documentation cannot support the clinical evidence required for proper care. Another possible deficiency is lack of specificity, like documenting pain instead of specifying sharp abdominal pain in the lower right quadrant, just saying pain, patient has pain. Vague terms like this fail to convey the full clinical picture and can lead to possible misdiagnosis or improper treatment. For coding, lack of specificity can result in the use of unspecified codes, which often have lower reimbursement rates and also receive increased scrutiny from the payers. During quality audits, non-specific documentation can result in failure to meet quality measures and benchmarks. Clinical validation requires detailed and precise documentation to confirm that the treatments and diagnoses are supported by clinical evidence. And then we have timing errors, such as a follow-up visit note being documented several days after the actual visit, which omits critical developments in the patient's condition. Delayed documentation can result in gaps in the patient's medical history or affect the continuity of care. Timing errors can cause coding inaccuracies as the sequence of events may be misrepresented and lead to incorrect DRG assignment and potential reimbursement issues. And quality audits may uncover these gaps, resulting in penalties and corrective actions. Clinical validation relies on timely documentation to ensure that clinical decisions are based on the most current patient information. Our next deficiency is omission of updates, like when a patient record does not reflect a recent change in diagnosis from bronchitis to pneumonia. Failure to update records with new information can lead to outdated or incorrect treatment plans. And in terms of coding, this can result in claims that don't accurately reflect the patient's current condition and ultimately lead to denied claims or underpayment. And for quality audits, outdated information can again indicate poor documentation practices and affect the quality scores. Clinical validation requires that the documentation accurately reflects the patient's evolving clinical status to justify the diagnosis and the treatments provided. Okay, the next one is template overuse. Templates are helpful, but we have to be careful with those. Copying and pasting the same note for multiple patients without any kind of personalization can get us into trouble. Over-reliance on templates can result in generic notes that lack patient-specific details and reduce the quality of care. And can lead to the use of non-specific codes and missed opportunities to capture the complexity of the patient's condition, again resulting in lower reimbursement. And quality audits may flag templated notes as being insufficient, and this could cause requests for additional documentation. Clinical validation efforts are hindered by the lack of individualized documentation and make it difficult to confirm that the care provided was appropriate and necessary. Illegibility, especially with paper charts, is a concern. Handwritten notes are difficult to decipher, such as unclear dosages for medication, and can lead to misunderstandings and errors in patient care. For coding, this can result in misinterpretation of the clinical information, incorrect code assignment, and reimbursement issues. Quality audits may identify illegible notes as a compliance issue and require corrective actions. Clinical validation depends on clear and readable documentation to verify that documented clinical information supports the care provided. Outdated information, this is referring mainly to the problem list. Resolve issues still listed in the problem list rather than the history record. These things can clutter records. You can see multiple conflicting diagnoses in a problem list, and it makes it difficult sometimes to choose or to understand what the accurate diagnosis is, such as listing acute bronchitis as an active problem months after it has resolved. Keeping resolved issues on the problem list can clutter the record and distract from current health issues. For coding, outdated information can lead to unnecessary codes being included in the claim, affecting reimbursement accuracy. And quality audits, outdated problem lists can suggest poor documentation practices and lead to further investigation. Clinical validation becomes problematic as outdated problems may not align with the current clinical picture. And redundancy, this kind of falls in line with the last one. Duplicate entries, I see this in the problem list quite a lot. Confusion in prioritization, listing hypertension and high blood pressure as separate entries can be an example of that, but maybe they're both listed on the problem list. Redundant entries can confuse the healthcare team and make it harder to prioritize issues. I don't think that high blood pressure is a good example, but two conflicting diagnoses, maybe hypertension and hypotension, because there was an acute condition, maybe a medication issue that caused hypotension, and now they're both there. Which is it? Okay, and I see this sometimes with hypo and hyperglycemia also. But redundant entries can confuse the team and make it harder to prioritize the issues and lead to duplicate coding, overbilling, and reimbursement challenges. It's going to come across an audit as a documentation inefficiency, and clinical validation requiring a clear and concise problem list to accurately reflect the patient's health status is going to be hard to achieve. And of course, once in a while, a deficiency that comes across is an incorrect diagnosis. This is when you should be receiving a query just to clarify one of the times. An example would be gallstones on the problem list when imaging has ruled out the condition. So we have conflicting information. Incorrect diagnoses can mislead future care providers and can mislead the future providers and lead to unnecessary treatments. It can result in incorrect code assignment and claim denials and recoupments during audits. If quality audits uncover the inaccuracies, it could even suggest potential fraud or negligence. And the clinical validation is compromised as the documented diagnoses do not align with the clinical evidence. And then lack of detail, such as simply stating diabetes without specifying type 1 or type 2 and the control status. Broad terms without additional context fail to convey important nuances about the patient's condition. Lack of detail can lead to non-specific coding, as we mentioned before, and as always affect reimbursement rates and not meet quality measure requirements. Quality audits may note the lack of specificity impacting the audit outcome. So validation requires detailed documentation to ensure that the diagnoses are supported by the specific clinical findings. And then incomplete problems such as significant issues missing or incomplete care plans, or example, a failure to list chronic kidney disease in a patient with a history of diabetes and hypertension, if it is there. Omitting significant health issues can result in incomplete care plans and missed management opportunities. Incomplete problem lists can lead to undercoding, impacting reimbursement, and potentially causing claim denials. During quality audits, incomplete problem lists suggest poor documentation practices and may trigger further investigation. Clinical validation is hindered by the lack of a comprehensive problem list that accurately reflects the patient's health status. And looking once again at the problem list, it's a critical component of a patient's medical record, providing a summary of the patient's diagnoses and ongoing health issues. Keeping the problem list updated is essential for several reasons. First, it ensures that all healthcare providers have accurate and current information, which is crucial for effective decision-making and continuity of care. Secondly, an updated problem list supports accurate coding and billing, as it ensures all relevant diagnoses are captured and appropriately coded. And third, it helps prevent errors by reducing the risk of redundant or outdated information. This can lead to incorrect treatments or misdiagnoses. So to prevent errors, regular review and updating of the problem list should be integrated into clinical workflows. This includes verifying the accuracy of diagnoses, removing resolved issues, and ensuring that new diagnoses are promptly added. And I'm going to add to this also avoiding the use of history of used inappropriately in the problem list or assessment and plan, unless it is referring to a history of and it's relevant. And while we're talking about history, an incomplete medical history, like not documenting a patient's past surgeries or significant family medical history, maybe an amputation, missing information about past illnesses and family history can impede accurate diagnoses and treatment planning. Incomplete histories can lead to miscoding opportunities and affect reimbursement accuracy. This might apply more to historical chronic lifetime conditions, congenital conditions, and things like that. Quality audits might identify gaps in the medical history as a documentation deficiency, and of course, clinical validation relies on the complete medical history to support the diagnoses and treatments. And inaccurate information, like incorrect allergy information, like recording that a patient is allergic to sulfa drugs when the actual allergy is sulfa-containing foods. Inaccurate details can lead to unnecessary avoidance of certain medications and treatments. Inaccuracies can result in incorrect coding, affecting reimbursement and potentially triggering audits. I think it's important to really be careful when it comes to sensitivities versus actual allergies and really clarify that. Quality audits may uncover these inaccuracies, suggesting documentation issues. Clinical validation depends on accurate information to confirm that the documented care was appropriate. And a lack of chronology, like documenting onset of symptoms without noting the progression or resolution of previous episodes. Disorganized entries make it difficult to understand the timeline of the patient's health issues. Lack of chronology can lead to coding errors affecting reimbursement accuracy and complicating claim reviews. Quality audits may identify chronological gaps as deficiencies. Clinical validation, of course, requires a clear timeline of the patient's condition to support the clinical conditions. Vague descriptions like documenting pain without specifying the location, intensity, or character. Non-specific terms do not provide enough information for accurate diagnosis and treatment. Vague descriptions can result in non-specific coding. Quality audits may note the lack of specificity. So we want to support the clinical findings with as much specificity as possible. Omission of relevant details. Sometimes it's hard, especially if you think a patient has access to it, to want to document things like morbid obesity or alcohol addiction, abuse, histories like that. So not recording lifestyle factors such as smoking or alcohol use that can impact the patient's condition can lead to an incomplete understanding of factors affecting the patient's health. Omissions can result in incomplete coding and can potentially cause claim denials. Quality audits may identify the lack of relevant details as a documentation deficiency. And as always, clinical validation relies on comprehensive documentation. Those things could be quite relevant. Okay, so I think we've touched on some of the most common issues. Addressing these common trends and errors in clinical documentation is crucial for ensuring accurate, complete, and reliable patient records. Regular training and adherence to documentation standards and continuous auditing can help mitigate these issues and improve the quality of clinical documentation, which not only supports effective patient care but also ensures appropriate coding and reimbursement and facilitates successful quality audits and clinical validation. And just a quick overview of our lesson. We covered understanding the importance of accurate documentation, some specialty-specific documentation issues, and there are lots more, but those I think are the most common ones. Best practices for improving documentation accuracy, and I think that comes down to just really keeping your problem list, med list, and history list updated and accurate. These were just some of the common trends in documentation errors and how they can impact coding and reimbursement and your audits. And as always, I want to thank you for your valuable time and attention. And I do welcome any questions, comments, anything you'd like to discuss. You're welcome to leave your comments in the discussion or comment area.